Welcome once again to ETCM. So we continue our FRCM discussion videos. So today we come across with three different cases actually. So starting the 4-year-old child, we have Dr. Riaz accompanying my presentations. So we have a 4-year-old child brought to the emergency department by his concerned parents. He has been lethargic and losing weight over the preceding 2 weeks, and he has suddenly become unwell with abdominal pain and profuse vomiting. On examination, he is tachycardiac, he is tachypneic and clinically dry. So what could be the most probable diagnosis you are suspecting in this child?
Sir, one possible diagnosis is juvenile diabetes mellitus leading to diabetic ketoacidosis, sir. So that's the possible answer for this case.
Why do you say so?
Because child has features like abdominal pain, vomiting, child is dehydrated. That's the major things, and otherwise that child is already tachypneic also, probably because of acidotic breathing. Then other than that, these are the only things that
is suggesting that this could be the diagnosis, isn't it? Okay, so the B part of the question, he has become increasingly confused and drowsy, and he loses consciousness currently. Now his respiratory pattern is irregular. So what complication are you expecting in this patient?
One thing is that maybe because of probably the worsening of acidosis itself is causing a respiratory pattern. But since there's a further fall in GCS, we should think of the complications of DKA. And most important complication is being the cerebral edema. So possible right now the issue will be cerebral edema.
Okay. So I know this is a very confusing case. That's why we put up this exact question in the discussion currently, because the FRCM videos and the FRCM literature is currently saying if a 4-year-old child presenting like atypical symptoms of abdominal pain, vomiting coming with altered sensorium, and patient currently tachypneic, tachycardiac and feeling very unwell with clinically looking very much dry, you are suspecting, you are looking forward in a case of DKA until and unless proved otherwise. So that is why exactly we are coming across this very atypical case, and we have to prove a point that okay, this could be the leading diagnosis which you are facing in this patient. So supporting this diagnosis, given this above scenario, what drug should be given immediately to this patient?
Now, the child has developed the complication of cerebral edema. Just like management of any cerebral edema, to save the life, we will have to immediately give the child mannitol or a 3% hypertonic saline. If you are giving mannitol, dose becomes around 0.25 to 0.5 grams per kilogram to be given over 10 to 15 minutes. Or if you are giving 3% saline, it becomes 0.25 to 5 ml per kg of 3% saline. Again,
3 ml to 5 ml per kg?
Yeah, 3 to 5 ml per kilogram.
Yes.
Again to be given over a period of 10 to 15 minutes.
Yes. So this question is quite confusing, I felt, because what they're saying is given the above scenario, what drug should be given immediately to this patient. Now if a third person is reading this question, probably if we are taking into account of DKA, the first drug is always you're looking up to IV fluids. But this scenario, that means the child is already in a state of cerebral edema, in which you cannot give further fluids, in which you are supposed to treat cerebral edema. So the option which we have is two main drugs are, one is mannitol and 3% saline. So that is why this question is quite confusing, like what answer to be done is very, very specific in this question. So coming to the DKA part, so let me start with the triad of DKA. What is the triad of DKA and how do you classify DKA in children?
The triad in DKA is that there should be acidosis. The pH should be less than 7.3 and the bicarbonate cutoff as per MRCEM guideline is 18 millimoles.
Okay.
Compared to adults where it is 15. In
yes.
Pediatric it's 18.
Yes.
And the next thing is ketonemia, and the blood serum, the serum ketone should be more than 3 millimoles per liter. And in adults the third triad becomes hyperglycemia and dehydration. In pediatric age group, hyperglycemia may not be there because even less than a cutoff of less than 11 millimoles per liter, the child can have DKA. So major things that we can see here will be ketonemia, acidosis and dehydration.
So you mean to say that hyperglycemia is not a separate entity, cannot be taken as a separate entity in terms of DKA triad,
Yes.
unlike what's happening in adults, isn't
Yes,
it?
yes.
Okay, fine.
And one more thing, since you asked the classification,
Mm.
again, according to the pH, again we can classify the DKA in pediatrics into mild and moderate into one sector and severe DKA into the other segment.
Okay.
If the pH is between 7.1 to 7.3, we can take it as mild or moderate.
Mm.
If it is further less than 7.1, we will have to take it as severe DKA.
Okay, all right. So, what are the other symptoms by which a DKA patient can present to the emergency department?
Just like
Now,
this,
in this question, we discussed about feeling unwell, feeling lethargic, very fatigue, losing weight, coming with abdominal pain and vomiting. That's a very atypical presentation, isn't it?
Yes.
So, what are the, maybe we could say, like, what are the other symptoms by which patient can present with?
Typically the child will be presenting with multiple episodes of nausea, vomiting. Child will be having abdominal pain. Because of acidosis, child will be having acidotic breathing and slight amount of altered mental.
That is rapid shallow breathing, isn't
yes,
it?
rapid Kussmaul's rapid shallow breathing.
Kussmaul's
will be
breathing,
getting.
okay.
And some amount of altered sensorium or confusion might also be there, sir. And other than that,
typical symptoms of polyuria and polydipsia can also be.
Polydipsia because of the diabetes mellitus
Yes.
itself, and dehydration. Dehydration is an important clinical symptom.
Okay. So, is there any peculiar smell by which patient can present? A smell of
Fruity
ketones can
odor
also
will be
fruity odor will be
odor
there.
of the ketones might also be
Yes. Okay. Suppose a patient comes with similar thing. What other intoxication you can suspect in this case? Give one more intoxication because patient can respiratory alkalosis. So, what other intoxication which patient presents with fast breathing, respiratory alkalosis pattern of ABG finding which you can get?
Tachypnea is salicylate poisoning.
Salicylate
It's one
poisoning.
It's a
Excellent.
drug which direct
Yes.
stimulates the baroreceptors
Excellent.
and causes.
So that will
tachypnea.
be our number one differential diagnosis when patient comes with altered sensorium and tachypnea when it comes to differential diagnosis of DKA.
Okay.
Now coming to management part. So what all are the investigation which you send from ER when you take a case of DKA?
From the ED, we should say first and foremost we will have to check the glucose, then we will have to check the urea and electrolytes, and to screen and of course send the serum ketones. And for sepsis is a very important cause that triggers DKA. So sepsis
It is a precipitant, isn't it?
precipitant.
Yeah.
So we will have to screen for the sepsis, and we will have to send this sepsis panel. That is the total count and cultures everything. And we have to take over blood gases to see the acidosis. So this will be the major investigation that has to be done in an ED.
ED. Okay. All right. So you have done the clinical entity. You have completed the management part. So you have done the investigation part. So how do you manage this case right from ABC?
Management is that here first and foremost in management of DKA starts with an IV fluids. In IV
What if the patient, in this case, the patient is having altered sensorium? Suppose the patient has probably he would have aspirated something. We don't know. So what if a patient with aspiration and coming with altered sensorium with high sugars, what will be the importance given to the patient? Is it from airway or is it IV fluids?
Here then it goes to the airway, sir.
Yes.
Because if the child has already developed a cerebral edema, and if you are giving further fluids, the chance of worsening of the cerebral edema will
Excellent.
be there.
Yes.
So then we will have to go as per the ABCD.
Exactly.
criteria.
So we need to know whether we are treating a genuine DKA case or are we treating a complication of the DKA. So as Dr. Ria said, if we are just treating a DKA, IV fluids are the mainstay of the treatment, be whatever it is. Now if you are treating a complication of DKA, just like maybe an arrhythmia, maybe a cerebral edema, or probably some hypokalemia, or maybe hypoglycemia even, then there is some difference in modification which has to be mentioned in the treatment, which we will come across in this discussion. Yes, please continue.
So first and foremost we will be starting the child on to correct the dehydration. We will be starting on IV fluids. So usually we prefer 0.9% sodium chloride NaCl only. In that itself we predict what's the dehydration of the child. In moderate to severe DKA we are expecting a dehydration of only 5%. So around 50 ml per kg.
You mean mild to moderate is 5%?
5% fluid deficit.
That means 50 ml per kg is a
50
fluid
ml per
deficit.
kg is
Okay.
the fluid deficit. deficit. While in case of severe DKA, we are expecting a fluid deficit of 10%, that is around 100 ml per kg.
Okay.
Okay. So this is the deficit, and along with that, next is the maintenance. In the maintenance, usually the IV fluid maintenance requirement for a pediatric age group is high compared to the management of DKA. We'll have to give a reduced dose for maintenance fluid when we are dealing with the DKA to prevent the complication of cerebral edema. So up to 10 kg baby, we will have to give 2 ml per kg IV fluids as maintenance fluid, and from 10 to 40 kg, we will have to give 2 ml per kg, 1 ml per kg as the maintenance fluid. If the child is more than 40 kg, just give 40 ml per hour as maintenance fluid. So in total fluid we will first calculate the fluid deficit, and we will be dividing it. Actually, we are calculating the fluid deficit for 48 hours. So we will be calculating the total fluid requirement. The fluid deficit, we will divide it with the 48, so that hourly how much fluid deficit is required, fluid deficit will be there, we can calculate it.
Okay.
Along with that, we will be adding the maintenance hourly requirement.
So the total fluid deficit, as of the way you have made me understood, is you have to provide the deficit volume and the maintenance volume.
Yes, sir.
And you have to divide the deficit volume for 48 hours. That means probably, as you told, if the deficit volume is like 100 ml per kg, you have to calculate 100 ml per kg for a period of 48 hours. So we have to divide by 48, isn't it?
Yes.
And then upon that, you have to add the maintenance fluid, isn't it?
Yes.
That is where the calculation of less than 10 kg, it is 2 ml per kg per hour. If it is from 10 to 40 kg, it is 1 ml per kg per hour, and if it is more than 40 kg, you have to add simply 40 ml, isn't it?
In case the child at the primary presentation is severely dehydrated with hypotension or raised to CRT or anything,
that means the child is in shock. Okay.
Then give fluid bolus of 10 ml per kg.
Okay.
And if the child is not responding to the initial fluid bolus of only 10 ml per kg, up to 20 ml per kg can be, one more 10 ml per kg fluid bolus for resuscitation can be given. But if you are giving any further boluses more than 20 ml per kg, we have to calculate how much extra boluses we have given, and we should subtract that amount, that is whatever fluid we give as bolus in excess to the 20 ml per kg that you are given, and that should be subtracted from the total fluid requirement that we have already calculated for 48 hours.
Okay. That is basically to prevent complication like cerebral edema, isn't it?
Yes.
Okay, so that is the fluid management part in DKA.
Yes.
So so once that is done, are we supposed to mention something about the electrolyte disturbance correction?
One the major complication of DKA is the chance of going into hypokalemia and hypoglycemia. First, we will have to make sure that patient doesn't go into hypokalemia. For that, we will have to add on 20 milliequivalents of potassium to every 500 normal saline infusion that we are giving, so that child doesn't go into hypokalemia. It's actually shift hypokalemia because the sudden reduction of glucose is there. And next thing is concerning regarding the starting of prevent hypoglycemia and start the insulin dextrose infusion. So usually we are targeting that we will with the fluids itself, there will be gradual reduction in the blood glucose level. So always for DKA we start with fluid resuscitation. After 1 hour of fluid resuscitation, we start on insulin infusion. So it's like a 0.05 to 0.1 international units per kg of insulin, that too diluted with a normal saline into a concentration of 1 unit per ml. We'll have to start the insulin infusion, and once the insulin infusion is started along with the IV fluids, once the insulin starts falling to a value less than 14 millimole, then we will have to stop the IV fluid of normal saline and shift it to 5% or 10% dextrose infusion and continue it along with the insulin. So next question, when to stop the insulin infusion? So here again the criteria is that the child's acidosis should improve, that the pH should come above 7.3. Next important part is the ketosis should resolve, that is the serum ketone should come less than 3 millimoles per liter. And next important thing is that the child should start taking orally. For the food the child should be able to take food orally. So pH has improved, uremia and finally the serum total blood sugar should has also come at least below 14 millimoles per liter. Then we can switch from insulin infusion to subcutaneous or infusion.
One thing I want to put into the limelight is mainly in FRCM what the unit of blood sugars is millimoles and not milligram per deciliter. So there is a definite criteria by which like we usually measure the blood glucose, and as Dr. Riaz said, like if it is below 14 millimoles, you can actually switch from intravenous insulin to subcutaneous insulin, and then further ahead with we can start either 5D or 10D according to the availability of fluid in the ER. Yes. So this is how you do things. How do you manage case in the emergency department DKA? So I would like to discuss one more topic under this. What are the possible major complications you encounter in a patient with DKA?
The expected complications are again the cerebral edema that I have already mentioned.
Yes.
Then the electrolyte issue that I have already mentioned, chance of developing hypokalemia and chance of developing hypoglycemia, and the chance of developing altered mental cerebral edema leading to seizures and all. And other than that, DKA. That's what I have remembered.
Yes. And there is one more thing. Maybe I would say like maybe 1 or 2 is due to like zealous use of IV fluids, patient can develop a state of pulmonary edema, or probably in the state of, just like cerebral edema, patient can develop a state of pulmonary edema, which can either result, maybe a child can have an AKI superimposing the infection or something, which is resulting in DKA. So he is a candidate for going for acute renal failure also. So these are parameters which has to be concurrently checked along with managing the DKA as such. So this is how things goes when a patient comes with DKA in the emergency department.
And one more complication that I have encountered with multiple, that especially in DKA part, is aspiration pneumonia.
Yes.
Which this complication has been mentioned in both adult as well as pediatric DKA. Aspiration pneumonia is also mentioned a complication.
Aspiration pneumonia. That's a very valuable point. Right. So we end this discussion about DKA